Good morning, good afternoon, and good evening. Thank you for joining us today for our webinar, Autonomic Dysfunction in Long COVID. I am Haley Culleton from Inside Scientific, and I am very pleased to be your host for today's event. Post-COVID syndrome, or long COVID, is now a very significant health problem. Over 1 million people reported persistent symptoms in the UK alone in February of this year. During today's webinar, sponsored by Finepress Medical Systems, Dr. Boon Lim and Dr. Melanie Dani from Imperial College Healthcare NHS Trust describe the presenting symptoms and diagnostic challenges for patients in their syncope clinic presenting with autonomic dysfunction in long COVID. They will also discuss possible mechanisms, wider research questions, and suggestions for management. So we'll now be joined by Danielle Koopman, Clinical Research Specialist for Finepress Medical Systems, who would like to say a few words. Danielle, the floor is yours.
Thank you, Haley, and thank you, Inside Scientific, for hosting this webinar. I would like to welcome all attendees who will join this webinar today. At Finepress Medical Systems, we aim to contribute to a better healthcare by providing hardware and software solutions for continuous non-invasive blood pressure measurements. The COVID-19 pandemic has and will have huge impact on global patient care. For me, as a clinical research specialist, it's especially interesting to see all the work that's being done in the autonomic testing labs to study the short-term and long-term impact of the pandemic, for example, in patients with long COVID. The pandemic has also changed the way how we at Finepress are in contact with our customers. Hospitals and researchers will use Finepress devices. In the past year, we increased our online presence by updating our website, being more active on social media, and of course by sponsoring webinars like today. We would like to inform you that we also give online product demos, and we often have virtual meetings with Finepress users from all over the world. So if you would like to interact with us in that way as well, please just contact us. Now it's time to talk about the webinar. We are delighted that with this sponsorship, we can contribute in spreading important knowledge about autonomic dysfunction in long COVID. Today, we have two speakers from the Imperial College Healthcare NHS Trust, Dr. Lim and Dr. Dani. Dr. Lim is a cardiologist and electrophysiologist, specialized in heart rhythm disturbances, pacing and syncope. He leads the Imperial Syncope Diagnostic Center, and is actively researching the best techniques for modulating the autonomic nervous system to treat atrial fibrillation and vagal syncope. Dr. Dani, our second speaker, is a consultant in general adult medicine and geriatric medicine, and she is part of the Imperial Syncope unit as well. In the past years, he was first author of multiple insightful articles, for example, on autonomic dysfunction in long COVID and on orthostatic hypotension in the elderly. I would now like to give the word to our speakers to start this webinar about autonomic dysfunction in long COVID. Dr. Lim and Dr. Dani, the floor is yours.
Thank you very much, Danielle.
So thank you very much, Danielle and Haley, and thank you to Finepress for inviting us to talk today on autonomic dysfunction in long COVID and our experiences at Imperial College Healthcare NHS Trust and our syncope unit over the last year. So as the world recovers from the devastation of the first and second waves of acute COVID and prepares for resetting and recovery over the autumn and winter, a second pandemic appears to be emerging, the problem of long-haul COVID. A recent bulletin from the Office of National Statistics in the UK announced that 1 in 5 people in the UK had persistent symptoms after 5 weeks of infection, and 1 in 10 people had persistent symptoms after 12 weeks. These may well be conservative estimates. So the REACT study, another study from Imperial College London, which interviewed over 500,000 people after COVID, reported that a third, so 37% of people, were still reporting one or more symptoms after 12 weeks. It's estimated that over 1 million people in the UK were affected in May 2021, with well over 500,000 people reporting that symptoms were interfering with their activities of daily life. Given that most of these patients are young or middle-aged, of working age, and a substantial proportion are healthcare workers, this has major implications for both workforce planning looking into the future and also the need to organise healthcare services appropriately to manage this increased demand. The bar chart on the right shows the frequency of some of the most common symptoms that are being reported, and this was again from the Office for National Statistics in the UK. By far and away, the most common symptoms are weakness, tiredness and shortness of breath, muscle aches and brain fog, and these are consistent findings throughout most of the studies. But around a year ago, or just over a year ago, we started to notice in our syncope clinic, as we're sure many others and many listeners here did as well, that a significant proportion of patients were being referred complaining of orthostatic intolerance syndromes or orthostatic intolerance symptoms. And a majority and a proportion of these symptoms could be related to autonomic dysfunction, as highlighted here with the red crosses. And this condition is really something that has been emphasized by the power of the patient voice and social media. This is certainly a condition of 2021 where social media platforms like Facebook and Slack were really able to gather peer support and the ability for people to connect about their symptoms and really perform some lobbying support and influencing policy. The top right shows a Facebook support group of over 40,000 members. And these were often patients, again, around a year ago, getting together and realizing that they were having persistent and similar symptoms that were often being dismissed or misunderstood by their healthcare providers. Part of the reason for this could have been the fact that most of the investigations that they were subjected to were subsequently normal, and so they were being told that they had normal tests and there was no obvious explanation of the symptoms, which understandably caused some frustration. This was highlighted in some of in the medical professions realizing that this. So this headline from JAMA, the Journal of the American Medical Association, reported as the numbers grow, long haulers stump experts, as well as headlines in the mainstream media reporting that people feel that they're not being recognized by their GPs and employers. And it is testament to the patient voice itself that the condition long COVID or long haul COVID was actually a condition coined by patients. This next slide here demonstrates, this was one of the first preprints or the first studies looking at symptoms post-COVID. And this was one of our preprints from late last year. And the purpose of this is just to highlight the vast range of symptoms and the heterogeneity of symptoms following COVID. So these are things ranging from changes in the ear canal or rattling breath sounds to a discolored nail. But again, this happened just over a year ago, we started to notice that a lot of patients, a vast majority of patients, certainly coming through our syncope clinic, were reporting orthostatic intolerance syndromes or symptoms of dysautonomia. So highlighted in the red circle, you can see over 90% prevalence of palpitations and tachycardias in this cohort. And then looking through the rest of these symptoms, there are substantial symptoms of autonomic dysfunction. So temperature dysregulation, fatigue, malaise, sexual dysfunction, and difficulty exercising, which can all be attributed to the autonomic nervous system. So we'd like to pause here and just ask the audience a question. And we're aware that many of the viewers of this webinar are going to have experience of long COVID clinics and patients reporting following COVID and long COVID. So the question is, a 35-year-old woman presents with fatigue, palpitations and shortness of breath on standing and walking, associated with a marked reduction in exercise tolerance from previously. She had an episode of COVID-19 infection 6 months ago, and the symptoms have persisted. She didn't require hospitalization and has normal exertional oxygen saturations, a normal chest radiograph, and a normal electrocardiogram. What is the most likely diagnosis? And one of the reasons that we included this question is just to demonstrate the heterogeneity in symptoms and the difficulty in diagnosing these. Appropriately, a lot of research initially and healthcare time and expertise was focused on the acute complications, of which there are many, and is the focus of another talk, but post-COVID sequelae, such as pulmonary emboli and myocarditis. But the focus of this talk really is then the symptoms that are persisting long after often when other investigations are normal. Often it is found that patients with persistent symptoms after COVID are not those that required hospitalization. And while this may be one large spectrum of post-COVID sequelae, it may be that there are several different diagnoses within this. So the answer that we were looking for in this was post-COVID autonomic dysfunction. And this was mainly because her initial tests were normal. She hadn't required hospitalization initially, suggesting that the chances of post-COVID sequelae would be less. But the drastic reduction in exercise tolerance and the orthostatic symptoms, so the fact that her symptoms got worse on changing to standing and walking, suggest this. So this next slide was just a snapshot of some of the early patients that we saw around last summer who were coming through our clinic. And this is just to highlight the nature of some of these patients. The things to notice on the far left is that the vast majority of patients were women, although not exclusively, and they were young to middle age. The oldest in our cohort so far has been 60. And as mentioned previously, unfortunately, but unsurprisingly, a substantial proportion of these were healthcare workers. The symptoms themselves could be vague if you didn't have a high threshold or a low threshold for considering autonomic dysfunction, often with fatigue, brain fog being the predominant symptoms, but palpitations in particular might point towards autonomic dysfunction. And almost all of them had some abnormality in either their baseline observations or their postural observations and changes from lying to standing. Another point to make is that by the time a lot of these patients had come to us, they'd had multiple investigations, which were all normal, and were feeling frustrated about their lack of diagnosis to date. So next, we would like to focus on a deep dive on one patient in particular that we saw, and this was one of the first, a 31-year-old female who'd had COVID in March 2020, so just as the global pandemic was announced. She presented 3 or 4 months after her infection with dizziness, lightheadedness, and fatigue, which was worse in prolonged postures such as sitting and standing, and particularly when she was premenstrual. And Dr. Lim is now going to talk through her tilt test data.
Thanks very much, Mel. So just coming back to the point of the question survey that we all answered earlier on, one of the key, in my mind, discerning questions that you could ask your patients about if you're suspicious of autonomic dysfunction as a cause for the long COVID symptoms is actually what happens to the symptoms when they stand up, particularly first thing in the morning. Because when somebody wakes up in the morning, it's after a typically prolonged period of sleep, let's say 4, 6, 8 hours. And during that whole period, they get slightly dehydrated. They're producing urine, they're sweating and evaporating underneath the sheets. So there's insensible losses of fluid from sweating, from respiration, and from urine production, whilst not being able to replenish that fluid. So patients who get up out of bed in the morning and feel the symptom onset the worst have a strong clinical index of suspicion for autonomic dysfunction in long COVID. And really, I want to set the scene because this is a tilt table test. And we condition the patients who attend for a tilt table test by giving them the exact same conditions, which are we keep them nil by mouth for 4 hours before the tilt. We typically perform the tilt in a quiet, dark environment, and if we can, not in a cold room. So in a comfortable but slightly hotter rather than cooler room. Because what we're trying to provoke is the similar conditions to try and get the autonomic dysfunction response going. And of course, you will know that tilt table testing was discovered by serendipity by Roseanne Kenny and Richard Sutton, and they publish on this in the Lancet after some wrangling with the editors. But effectively, they were studying carotid sinus syndrome, and when they tilted patients upright, they found that patients who previously fainted would go on to get a vasovagal response. So they would get a blood pressure and heart rate drop. And this tilt test has been developed and reiterated to the point that we do a 5-minute supine test, followed by a 60-degree head-up tilt, followed by 20 minutes held at this passive tilt. A passive tilt is where the tilt table test is held upright for that length of time before sublingual GTN or nitrate is given to enhance the vasodilatation in the peripheral circulation and also the splanchnic bed. And this pulls the blood down and accentuates any vasovagal response. But in the context of long COVID, we see a patient here who has, in the first 5 minutes, you can see here, so time on the x-axis is indicated there. Each bar that you can see in the column is a 2-minute bar. So at 5 minutes, you can see the first of the vertical lines. And you can see that her heart rate drifts slightly lower, perhaps as she gets used to lying down in this dark environment, and drifts from somewhere like 85 beats per minute to somewhere around 68 beats per minute. Her blood pressure, if you ignore the artifacts which come on every 30 seconds or so, show an average of about 110 over 65 in the first 5 minutes in the supine stage. So if you look to the first vertical line now, she is tilted upright, and immediately on being tilted upright, she accelerates her heart rate to 105 beats per minute. And the most striking difference that I want you to have a look at is actually what happens to her blood pressure seen on the top gray trace. You can see that the blood pressure beyond the artifact spikes that you can see every 30 seconds start to show an oscillatory pattern, which means that on one moment in time, her blood pressure can be as high as 130 over 78, and then 10 seconds later, it drops to 95 over 60. And 10 seconds after that, it goes up again to 125 over 72. And this yo-yoing of blood pressure going up and down again and again in a cycle of typically 10 to 15 seconds is mirrored by a yo-yoing that you can see in her pulse rate. And if you look particularly at the time interval between 14 and 16 seconds, you can see the heart rate does vary by from 80 beats a minute to about 118 beats a minute. And so that significant variation and yo-yoing of heart rate and blood pressure is what we've started to understand as contributed by significant oscillations in the sympathetic nervous system response to standing. And this is not normal. So in a normal patient, you would not expect this exaggerated oscillatory pattern to continue to persist throughout this process, and you would also not expect the patient or a normal patient to have this response associated with symptoms. Now, this particular 31-year-old woman, who's one of my first patients with long COVID dysautonomia, happens to start to get symptoms within 30 seconds of being tilted upright, where she starts to feel dizzy, lightheadedness, fatigue, and brain fog, and all these symptoms are reproduced on standing. So the key point and the key lesson to take home is one of the most discerning questions, which I said before, is to ask, are your symptoms consistently worse on standing? And that is a clear clinical pointer. And this is the physiology, perhaps, that explains some of your symptoms. You can see also very clearly here that she doesn't actually drop her blood pressure. The average blood pressure is not reaching a point at which you would get vasovagal syncope or syncopal symptoms. And if you think about the other type of patient that we might see in this cohort, we remember the patients with postural orthostatic tachycardia syndrome, a group of patients who existed even before COVID. And in my view, there is a very clear overlap of the constellation of symptoms of those patients expressing POT symptoms and those expressing long COVID symptoms. You can see at the end of this trace at about 19 minutes and 15 seconds, the patient is so symptomatic, and essentially all those vertical lines that you see are symptom markers, which means she's telling the tilt nurse, I'm feeling unwell, and at that point, she says, I can't take it anymore, stop the test. And this is a very, in my view and experience, a premature stop, because for vasovagal syncope, we would normally continue the tilt test and perhaps even give GTN to look at the profound drop in blood pressure, which we don't see here. But this patient is already highly symptomatic. And so we have a very clear diagnosis in this patient. Now, her story happens to be told very well in a patient video, because she was kind enough as one of my initial patients to share her narrative of healing afterwards. And I would urge you to watch her video, which we'll provide at the link at the end of this webinar. Now, these are some of the other patients, just a selection of a few, to show you how varied the response can be. And so if you look in the top left-hand corner, this is a patient who, after COVID, has developed significant pre-syncope, and I would argue from this trace has a pattern consistent with vasovagal syncope, because the blood pressure really does fall quite early on, within the first 6 to 7 minutes of tilting, to a point at which she could come close to losing consciousness. So all I'm highlighting is that there is a spectrum or a range of patients. And if you switch over to the middle top trace, it's a very similar trace with perhaps more profound oscillations than was seen in the first trace that are highlighted. And similarly, on the third trace, which is the top right corner trace, here we see a patient with long COVID symptoms super exaggerated in the first 5 to 6 minutes of her head-up tilt, with that very marked oscillation in her blood pressure that you can see there, almost like an artifact in black. And towards the end, following GTN administration, you can see that her blood pressure starts to fall, and she goes on to develop a vasovagal type response. And this was a patient who lost consciousness as well. And then if you look at the trace on the bottom left and bottom right, again, they're very similar. And if you look at characterizing the delta heart rate for each of these traces, you may find that they sit at around the 30 beats per minute mark, some a bit lower, some a bit higher. And one of the key things in trying to characterize these patients is not so much to be fixated with the diagnosis of POTS or not POTS, but really to give a description of the physiology of patients' oscillations coupled with symptom burden. So in the trace in the bottom middle, which I find fascinating, there is actually a huge surge in the blood pressure, which actually goes up and the patient becomes hypertensive, associated with tachycardia and with significant oscillations. And this patient was highly symptomatic of a long COVID symptom profile. I'm also sometimes very humble and very stumped by traces that I don't fully understand and are slightly out of proportion to the patient's symptoms. And this was a more recent patient that I saw who had really done everything that we had asked her to do. So the management strategy for long COVID will be discussed in a short while, but she was doing all those things and still getting significant palpitations, vibration in her arms and legs, temperature dysregulation, nocturnal waking with palpitations, constipation, insomnia, and her heart rate would vary between these two values, 68 to 120 beats per minute, who, as with most of the patients that I see, have had normal echoes, chest x-ray, and Holters. And you can see here that she mounts a tachycardic response from a baseline in the first 5 minutes of supine position of 80 up to about 108 or 110. And in the first 10 minutes of tilting, that's where she stays. And as I said, for POTS to be made a diagnosis, you need to cross the magic threshold of 30 beats per minute. But you can see here, her trace doesn't show so much of a gross oscillatory pattern as the previous traces showed. So if I just now compare it back to the previous trace, you can see the oscillations here being very grossly seen with a cycle length of about 10 to 15 seconds per oscillation between up peak and trough. And here, in this particular case, it's much more high frequency than that. And so it is a bit more difficult for me to explain her symptoms. And I just wanted to highlight that we still do not understand everything there is to understand about autonomic dysfunction. And we certainly do not understand this new illness, which we call long COVID. So keep our minds and our hearts open to new ways of understanding and learning. And in this particular case, because of a hunch that I had with the nocturnal waking, I gave her a H1 antagonist, antihistamine, which happens to be fexofenadine, 180 milligrams once a day. And I gave her a sedating antihistamine at night. And this was the thing that really changed her symptom profile. So once again, I will admit that I am still learning. My patients are actually teaching me more than I am learning from the community. And as I say, learn with an open mind, because the people who have the most vested interest are the long COVID groups of 41,000 patients you saw Mel talk about. But there is a long COVID in doctors group as well within the UK who have written extensively within the BMJ. And one of those patients is actually a close friend of mine who's been out of work for the last 6 months because of long COVID. So it really hits home on so many levels, because this is something that I see in clinical practice, but I also see my colleagues suffer with. And guess what? None of us really fully understand what's going on. But the physiology doesn't lie. This is what we are looking at when we look at the traces. Mel?
And this open mind is required for understanding what exactly is the role of the autonomic nervous system in acute COVID and also in post-COVID syndrome. So the autonomic nervous system has been implicated during acute infection, and it's thought that the sympathetic nervous system mediates the well-documented cytokine release syndrome, which occurs between 10 and 14 days and is classically associated with an acute deterioration in symptoms. We know that the SARS-CoV-2 virus binds to the ACE2 receptor, thus increasing circulating angiotensin II and activating the renin-angiotensin system. And it is hypothesized that it's this exaggerated renin-angiotensin syndrome and sympathetic nervous surge that can cause the cardiac arrhythmias and cardiac death in acute COVID. Not only that, but there have been multiple case reports of acute dysautonomia in patients on the intensive care. So wild fluctuations in heart rate and blood pressure, which have been attributed to this. And a couple of case reports, I think just one, of vagal nerve stimulation during this phase of cytokine release syndrome with a subsequent attenuation of Crohn's cytokine. Not only that, but the phenomenon, the very well documented phenomenon of happy hypoxia, which is when patients when are very unwell with life-threatening hypoxia, have an apparent lack of air hunger or dyspnea, and this is thought to be mediated by an autonomic impairment in interoception, so an inability to see for the body to realize the extent of hypoxia. But there's more attention about the role of the autonomic nervous system in long COVID. So along with ourselves, multiple other groups are publishing case series, case reports, and hypotheses about the role of the autonomic nervous system. And multiple groups have found a series. Of particular interest was the paper by Kamal Schumann et al. From the Mayo Clinic, who looked carefully and did a retrospective analysis of all of the patients referred to them following COVID infection, and found that actually the majority of patients, so 40% of patients, would have orthostatic intolerance symptoms without documented heart rate or blood pressure changes, with about 22% of their cohort having features which would fit diagnostic criteria for POTS.
So Mel, I'd just like to say that in the context of the oscillations that we've seen on the traces that we have shown, this single blood pressure measurement strategy to document changes in blood pressure and heart rate may well miss the oscillations. And if we said, as I was trying to allude to in describing the traces, sometimes you might miss it. So don't necessarily discount the fact that you might have autonomic dysfunction and a reactive sinus tachycardia just because you might be catching the trough of the yo-yoing oscillations, right? So it is important to put that physiology in the context of these reports, particularly if the reports are using a manual blood pressure and pulse check, because where do you capture the blood pressure and pulse if it's oscillating every 10 seconds?
Yeah, and one of the other things to highlight is that it does seem to be, exactly as you're saying, a spectrum of features, so a spectrum of autonomic dysfunction, of which there may be subtypes, as there are in POTS, but it's very difficult to tell at the moment because it's such an early stage in the characterization of the disease. So coming on to our next question for the audience, just before we go on to the physiology of autonomic dysfunction in COVID, which of the following is not associated or a predisposing factor for developing an orthostatic intolerance syndrome? Joint hypermobility, mast cell activation syndrome, rheumatoid arthritis, and bed rest. And while we wait for the audience to vote on this, one of the reasons that this question is important is just thinking we still know very little about this condition, as Boon was alluding to. This is something, a disease that has evolved over the last year or year and a bit. And so understanding risk factors or perhaps patients who have always been at risk of developing orthostatic intolerance syndromes, which may have been unmasked by COVID or long COVID. And so understanding what are the fixed factors that the patient should also be aware of when they're developing symptoms. And the answer to this, and we'll explain this a bit more in physiology, is rheumatoid arthritis. It's a acute inflammatory condition with no associations that we know of. So Dr. Lim is now...
Yeah, so I was just going to try and pick up on some of these points. So the reason that joint hypermobility syndrome can lead to developing an orthostatic intolerance syndrome is, if you think about what joint hypermobility is, it's generally a defect or a problem with collagen. Collagen being the elasticy, spongy bit of your tissues that hold things like your ligaments and your tendons together. So when you're very hypermobile and you're able to, for example, hyperextend or hyperflex your thumb, touching your wrist, for example, you can imagine that that same collagen defect in deposition will also affect the collagen in your lower limb vessels and in your splanchnic bed, which are the vessels that supply your gut, which can be splayed out to feel a football field. That's how much area, the surface area of the villi in your gut can take. And just imagine if your vessels are very spongy and very compliant, what can happen when you stand up is that the vessels will accommodate a lot more blood. In other words, gravity pulls blood, and instead of having a very fixed tube that just expands slightly, somebody with joint hypermobility may have a tube that expands a lot more and takes a lot more blood down, therefore triggering the orthostatic intolerance syndrome. So that's an explanation for that. Let me come on to the next slide, which is the mechanism which explains how you might start to develop orthostatic intolerance syndromes. So in as far as long COVID or COVID infection is concerned, there could be a direct infection. So this is all theoretical, but it's plausible that there could be infection of the extracardiac postganglionic neurons or brainstem, and therefore it prevents an effective efferent action of nerves on the end organs. There can also be potentially autoantibodies to the virus that so happen to act on the G protein coupled adrenoreceptors in the vascular bed, effectively rendering your noradrenaline unable to cause vasoconstriction because all those receptors are already blocked or taken up. And this, I think, could be explained slightly easier if I did a very quick screen share, which I'm going to do now. So I'm going to start by explaining, using an illustration from stopfainting.com, which is our website, how it is that you can develop an orthostatic intolerance symptom. So just imagine this. If you're standing up And when you first stand, you have a circulation volume consisting of blood, which is this red stuff in your brain, in your heart, in your circulation, in your lower limbs, and in your gut. And as you stand up, what happens is that the blood pressure falls slightly because blood starts to pull with gravity down to the lower limbs. And if you stand for a bit longer, the blood pressure can drop now to from a green or normal level, say 110/80, down to say 90/75. And this causes an emptying of your blood from your heart into the lower limbs. Now, I'm just going to start to share a different screen now. So what I'm going to illustrate for you now is what happens. So your blood pressure has fallen down there. And this is as a result of blood pooling down to your lower limbs. And sometimes after a large meal, which is a very common discerning question you can ask your patients as well, how do they feel after a large stodgy meal? You can fill up the gut with blood. And effectively, the gut's blood is filled up because it wants to take away the nutrients that are being digested in your gut after a large meal. The net effect is your heart volume is reduced, so the right atrial filling and therefore the cardiac filling is reduced, and that reduces the stroke volume. The stroke volume is the volume of blood being expressed or moving out of the heart every heartbeat. And this impairment in stroke volume activates the baroreflex, which are mechanoreceptors in the neck that don't stretch as much because the heart is not beating so much volume at every heartbeat. And it causes the brain to activate what's called a fight or flight response. And this fight or flight response, also known as the adrenaline response, is what triggers a lot of the symptoms, in my opinion, of long COVID or orthostatic intolerance syndromes, because it does cause a reactive tachycardia. And we know why that needs to happen, because heart rate times the stroke volume maintains the cardiac output. And so if you don't have enough blood circulating because the stroke volume is low, then boy, do you want your heart rate to be higher so that you can maintain the cardiac output, to maintain that flow. You also have adrenaline causing an impact on the lower limbs here to cause vasoconstriction, to push the blood back up to the heart to reverse the effect. And therefore, this vasoconstriction is a helpful thing to happen. It also vasoconstricts the splanchnic bed. But what are some of the other negative impacts of having high adrenaline all the time? Now, adrenaline can impact the respiration rate and can give you this sense of inability to catch your breath or take a deep enough breath. And so, in my opinion, a lot of dysfunctional breathing that we see in patients, which are shallow breaths, breath holding, and inability to breathe properly, for example, when doing minimal exertion. This, I think, is underscored by a high level of adrenaline that affects a very complex cardiorespiratory system that impairs the patient's perception of breathing. So the oxygenation is fine, lung capacity is fine, but the subjective sense of being unable to catch your breath is very high. The other thing that it could do is adrenaline, as you know, makes you very vigilant or hypervigilant. It's meant to make the gazelle grazing in a savanna be very aware of the blade of grass swishing and the lion hiding behind that blade of grass. That's why we have adrenaline, to make us acutely aware in terms of our auditory, visual, and interoceptive ability. This can be very unhelpful in the context of a chronic flight or fright stage. And this in itself can also lead to problems with sleep and insomnia. The last thing I will highlight is adrenaline itself acts on the gut directly, because if you were running from a tiger or a bear, would you want your gut to be churning? Would you want to be having lots of peristalsis? No, you would shut that down. And so it's fairly common, actually, for patients to manifest IBS-like symptoms, irritable bowel-like symptoms, with alternating diarrhea and constipation and crampy pain, because the gut is not working as it should. So I'll stop the screen share and come back to the mechanisms on this slide. Mel, can you see the slide again?
Yes.
Good. So on this slide, you will see that when you decrease the plasma circulating volume from the acute illness, this is one way that you can exacerbate the symptoms here that we've described. And this symptom exacerbation will continue to be worsened if you're feeling so unwell that you don't want to drink. So this leads to postural symptoms and fatigue that promotes bed rest. Bed rest promotes deconditioning, and deconditioning in itself promotes further decreases in plasma volume. So imagine this, you are flawed with long COVID for 2 weeks. And in that 2-week period, you're not really spending much time upright. The physiology of this is that your renin-angiotensin-aldosterone system doesn't have a chance to fight gravity. And so instead of having that water retention with a lot of aldosterone, renin-angiotensin, you are down-regulating that pathway and perhaps losing more water and salt. And therefore, if you're on prolonged bed rest, because you have to be, because you're so fatigued, this is a way that exacerbates this vicious spiral. So it's very important to understand the physiology of bed rest and how this may contribute to long COVID symptoms as well.
So the management principles that we suggest are in line with management principles for other orthostatic intolerance syndromes. And these are all based around some of the physiology discussion that Boon has just made. So improving circulating blood volume. The first and most important thing to comment on is the power of education. So using either a patient website or patient information leaflets to explain the physiology in detail, because if the patient then understands that, they can comply with conservative measures in more detail. Ensuring fluid and salt repletion. So in terms of fluid, aiming for 2 to 3 litres of non-caffeinated fluid per day, with front loading if possible, so that the person has the benefit in the morning and throughout the day. And encouraging salt repletion, particularly if they're hypotensive. So aiming for 6 to 10 grams of salt per day or 2 teaspoons. And on that note, it may be helpful to encourage the patient to buy a portable blood pressure monitor, not so that they can become obsessed with their numbers, but so that they can just develop an idea of their blood pressure and their heart rate if possible, and their postural responses, and they can look at responses to treatment. Encouraging them to get compression garments or to be supplied by their family doctors, so in particular abdominal binders and compression stockings involving compression of the vascular beds in the thighs, the buttocks and the splanchnic vessels to improve blood pressure, as well as physical counter-pressure manoeuvres here modelled by a member of our team, and explaining to the patient why these are helpful and to encourage them at the onset of symptoms may be all that's sufficient. So these conservative measures may be all that's required. Having a way of regular contact with the patient, whether or not it's via an app-based system, telecommunication or telemedicine, or clinic visits, but in some way having a service where you can have two-way communication with the patient to see how they're responding to these measures, and particularly if they are able to measure their heart rate and blood pressure responses. Often management may be done remotely, but if the symptoms don't respond to these conservative measures, then pharmacotherapy may be required, either if they're hypotensive, and this is problematic via fluid expanders and alpha agonists, or if they're exhibiting a adrenergic picture or a POTS type pictures, beta blockers or ivabradine. But that's really depending on their symptom profile, and that will be taken in account with their underlying physiology and their response to these conservative measures. One of the questions that we're asked most commonly in the clinic is what can the patient do about returning to exercise? We have to remember that these patients are people who are of working age. They're often fit, and as soon as their active infection is over, they may want to go back to their 15-hour day at the office, followed by gym. And one of the strongest things is to emphasize the importance of pacing and gentle recovery to exercise. And just bearing in mind that these are some of the guidance that we give, and this is for patients with autonomic dysfunction post-COVID, not patients with myocarditis or pulmonary emboli, for which the advice would be different. And this is based on the advice we give, but also a paper which we would recommend in the British Medical Journal from earlier this year, written by David Salmon and colleagues. So the principles are just to ensure that the patient is asymptomatic from acute infection for about a week before starting, and with no features of ongoing fevers or anything else. And really, that to emphasize, and it can't be emphasized enough, the importance of graded exercise. So starting at negligible or very light exertion levels, ideally recumbent. And this may involve just lying on a mat and breathing to start with. It's important to spend at least 7 days, at least, at each phase before progressing. Many patients will find that this is not enough and they need to speed up. And again, patients will often say, I just wanted to try and run a half marathon to see if I could. And that is often associated with a significant regression in symptoms. It's important to advise patients to drop back a phase if they notice that it's a particularly arduous workout, if their symptoms recur or they have excessive fatigue, and to only exercise if they're fully recovered from the previous day. This can be frustrating, it can be boring, and it does involve just emphasizing the importance of patience. Advise them to warm up and warm down after every session as normal, and just to closely monitor, either logging or with a diary, mood, fatigue levels and other symptoms. And this is just an example. So it's an example of a phase that we might advise in patients who are returning to exercise with particular orthostatic symptoms. So as I mentioned, the first phase would be very gentle, lying on a mat, stretching, perhaps doing some core exercises, but not really considered exercise outside of this picture, but just something for the patient to feel that they're doing something. When they're able to, so at least after 7 days, to increase the intensity to very light exertion. So again, we're not talking about even getting the patient out of breath, but to start a recumbent exercise by starting at what they can, but this might be 10 minutes. And then over time, increasing this recumbent exercise by a couple of minutes a day until they have a reasonable exercise level. This might take months, it might take longer. But once they're able to achieve this 45 minutes a day as a recumbent exercise, they may then want to introduce upright exercise. Similarly, a short amount that gets up titrated as the recumbent exercise gets down titrated. And finally, and this is the million-dollar question as to when they can return to their normal exercise plan. So this is some advice, and it's just really emphasizing the phased return and the monitoring of symptoms and dropping back, and advising patients that while we hope at some point they'll get back to their normal exercise levels, this may take time.
So Mel, thanks. You've talked what about the physical strategies, which includes the very nicely summarized slides in the last 2 sessions with the exercise and the physical maneuvers, including drugs. But in my experience, there is a very fundamental shift in the way that we provide healthcare, and this is to promote wellness. And this is something that I found experientially that LongCOVID groups and Facebook groups have allowed patients, including the LongCOVID in Doctors patient group, to really come and push the members in the group forward collectively through support and through a really different kind of healthcare approach, which I would like to embrace. And in my mind, if I try and bring it back to the autonomic nervous system, if I said to you and showed you my finger and I say, move your finger up and down, you can very easily move it. And that's very simple. It's controlled by the conscious or somatic nervous system, this movement. If I said to you, Mel, I want you to move your heart rate higher or lower, how would you do that? Could you think your heart rate lower? Could you think, how can I move my heart rate and make it go down? The answer is not through the somatic nervous system, but perhaps through the autonomic nervous system. And the window on a top-down approach into the autonomic nervous system is through an expression of a thought or feeling that is positive. And in particular, the feeling that has been shown time and time again in HRV studies are predominantly gratitude, compassion, love, and forgiveness. And these are some of the things that are coming through that I actually, as physicians, we don't embrace enough, but I think we should. and we should acknowledge with the patient's education, and we should listen to the patients and get them to express their emotions. And actually doing that exercise every morning for 10 minutes and every evening before they sleep for 10 minutes, not in terms of how lousy they feel, but how lucky they are that they're alive, that they have a house to live in, that they've got family around, and anything to be grateful for, including the fact that they now know a bit more about long COVID than they did prior to meeting the long COVID group or to meeting a physician. So I think this goes a long way. And actually, if you couple that to a high level of feeling that would be called meditation, which has been shown to enhance vagal tone, enhance attention, and increase heart rate variability in health. Now, that's a top-down approach. I think it's particularly powerful to promote wellness with a bottom-up approach, and you can do both those things together. So we talk about the concept of a perfect breath, and I would urge every one of you listening to this webinar to read this phenomenal book by James Nestor called Breath. And it has been one of the most game-changing books for me, because it defines the perfect breath as that breath which is very slow. And I guess my own interpretation of that is to use diaphragm breathing. I'll describe what that means in a short while. And with a cadence of 6 breaths per minute, or 5 to 6 breaths per minute. And this kind of deep breathing exercise has a direct influence on heart rate variability. And when coupled with meditation or a positive thought, I think you can down-regulate the fight or flight response, as hopefully I will show you next. So, Mel, I'm going to switch screens now, and I have started recording, and I will show you how disordered my heart rate pattern is as I've just been presenting the last 2 slides. I'm going to try and breathe now and express some gratitude for being invited by FinoPress to do this talk. Thank you, FinoPress.
So what Boon is doing now is using a heart rate variability biofeedback device. And so he has an earlobe plethysmograph, which is attached to his ear, which is measuring his heart rate and as a result, and also his heart rate variability. And via Bluetooth, that is transmitting information to his laptop. And it shows, just looking at the screen, his heart rate and his heart rate variability, so the interbeat interval. And as you can see, or as you may be able to see now as he's breathing, there's a breath pacer on the right. So he's breathing 5.5 seconds in and 5.5 seconds out. And what we see is on inhalation, we know the respiratory sinus arrhythmia is that the heart rate increases on inhalation and decreases on exhalation. And so consciously breathing and breathing at a particular frequency can influence the heart rate and the heart rate variability response and the respiratory sinus arrhythmia. And we can see during the talk now, so he's sitting, he's concentrating, he's expressing feelings of calm and that he's not on a talk. And he can see, he might be able to see his heart rate variability. So it's increasing very regularly, very smoothly and predictably on inhalation, and it's decreasing on exhalation. And that very predictable pattern is something that we see often at this frequency of breathing. And if you compare that to just a couple of minutes before when he was talking and wasn't concentrating, a very jagged, flat, unpredictable, chaotic rhythm we saw there. And so what this shows is that if you consciously breathe and you pace your breathing and you combine that with the thoughts of gratitude, you can influence not only your heart rate, but your heart rate variability, but also the heart rate variability pattern. So you can see now it's looking like a sine wave. So very regular, very smooth and very predictable. And the green, blue and red scores on the below, this is just, again, it's useful for the user to be able to look at and to get an idea of what he's doing, is the cardiophysiological coherence, which is a value calculated from the power spectral analysis of the heart rate variability. And a higher value suggests a more regular inhalation and exhalation and a more regular heart rate variability pattern to breathing, and does correspond with maximal gas exchange an alignment of systems, and also the feelings more of calming the nervous system. And you can see now he's practiced a lot, and Boon does this a lot, so his coherence scores are very high. This takes practice. If it were me, it would be much lower. And so regular daily practice of this once or twice a day, even just 10 minutes, can be enough to get this pattern. And the reason that the biofeedback is helpful, because it shows the user this direct sort of real-time response of heart rate and heart rate variability to breathing. So you can see the effects of your breathing on your physiology. And that can be very important. And often we don't want people to get obsessed then with their numbers, which they don't. They can actually get rid of the device and just practice their breathing for themselves.
So Mel, I've stopped doing that breathing technique in the last the last 30 seconds, and I can already tell that my trace had a blip there. But I must say, I feel so much calmer now. Yeah. And just in a short time, whilst doing this webinar, I've been able to downregulate my stress levels, as one would imagine delivering a webinar might cause. So I think personally, it's a very effective tool. This particular tool is called HeartMath, and we'll put a link to it in the webinar notes below. And I think can be very useful in downregulating an acute sensation of stress, which I was feeling, and now I'm chill.
And while Boon just continues with some deep breathing for the rest of the study before the Q&A session, just to mention that there's still a lot that we don't know about long COVID and long COVID autonomic dysfunction. So this is still an area that needs a lot of research, and there are associations, and there are just other things that we don't know. So we did mention earlier the patient who responded to an antihistamine. There are some possible associations with mast cell activation syndrome, and obviously other associations with POTS that we're aware of, such as joint hypermobility syndrome and autoimmune phenomena. This is an area that's having substantial research in, rightfully so. So alongside the acute hospital studies, there are studies into long COVID. And any look on clinicaltrials.org will see that over 300 studies are looking at long COVID alone. So most important, well, not most importantly, but first things first, is characterizing symptoms and profiles. So functional impairment patterns, symptom profiling, dysautonomia profiling, and looking at immunology and sensitization responses to the condition. Interventions include exercise programs, rehab programs, in muscle training and breathing programs, including singing. And actually, one of our colleagues is involved in the English National Opera and using singing in long COVID to improve breathing and improve symptoms. So lots of different type and alternative interventions for this. And what Boon was talking about, the bottom-up and top-down approach to wellness alongside everything else. And then finally, into drugs. So dietary supplements can be very varied, from Chinese medicine through to monoclonal antibodies. Here in our unit, we're profiling. So we're doing autonomic and symptom profiling, along with associations with mast cell activation and autoimmunity in collaboration with our Swedish colleagues. And we're also looking at interventions such as heart rate variability biofeedback, as Boon has just demonstrated. So in summary, long COVID and long COVID autonomic dysfunction is having a massive impact and symptom burden, and there are implications for workforce planning, for healthcare services, for planning services, and that's a whole different talk. It is misunderstood, and there is still a low awareness amongst hospital physicians and family doctors, and frustratingly, diagnostic tests can often be normal. Patients can feel that they're invisible, that they're not being heard. We believe that autonomic dysfunction may be driving many symptoms, and the simple practical measures may be all that's needed, but we need more work in that field. And this condition is really just a testament to the power of the patient group, the patient voice, and social media in giving us valid lived experience and driving these research questions and these research agendas forward. So we've included, and these will be on the website, some resources that we use to give patients, so webinars, our education website, and patient information leaflets. And we've also included references from this talk. So thank you very much for listening. And we have time. We did talk for quite a while, so we don't have much time for the Q&A, Boon, but if we could kick off, and I will start by asking you some questions. So, Boon, in your practice, could you describe the rationale for beta blockers over ivabradine and fluid expanders in post-COVID POTS? And typically, how long should a patient take it before weaning off?
Okay, so first thing to say is there's no evidence base to suggest any of these management strategies. These all come from the experience with patients with other orthostatic intolerance symptoms. That being said, if I look at a trace and if I see that a patient is hypertensive with COVID, so you'll remember that in one of those 6 panels of slides that I showed, one of them showed persistent hypertension on a tilt up. The blood pressure actually went up by 40 to 50 points. That's the kind of patient, together with tachycardia, that's the kind of patient that I would start by giving propranolol 10 to 20 milligrams BD. In most of the other cases where the patient starts off with a low resting blood pressure, let's say 102 over 80, and on head-up tilt, they oscillate between, let's say, 85 and 110, then that patient with a low blood pressure state may well have a blood pressure that's further reduced by beta blockers. So the beneficial effect, which is the anti-adrenaline effect, may be mitigated by the lowering of blood pressure, which is a direct impact of beta blockade. And in that patient, I might defer to ivabradine. Having said that, beta blockers and ivabradine are not my top choice agents for patients with autonomic dysfunction, because I often think of the tachycardia as a responsive tachycardia due to something else, i.e. blood pressure or blood falling down into the lower limbs when you stand up. So if there was a better way, and the better way could be to ensure and nag your patients to drink 3 liters of water and have more salt and have compression stockings, all the stuff that you talked about, and that improved their tachycardia, that would be the best way. Now, failing that, the other way that we could do that we could indirectly reduce tachycardia is to start on an agent such as fludrocortisone or a plasma expander, or midodrine, which is a alpha agonist that serves to vasoconstrict the peripheral and the splenic vessels. And with the principles of treatment here, I would go for at least 6 to 12 weeks of treatment continuously. If you decide that the patient is so unwell and they need drugs because they've done all the conservative strategies and that has not helped, then I would commit them to a 6 week to 3 month period of continuous medications and really reassess to see, even in that time period, whether they need up titration, for example, of the midodrine. And at that time, 3 months later, I would hope that everything that we would have given them in terms of conservative strategies, the top down and bottom up approach, would help to mitigate or reduce the sympathetic expression. And at that point, if they're feeling better, I'd be looking to wean down the drug. So the kind of short answer is 3 months, Mel. 3 months.
Very good. And then obviously, as we were talking about different ways of working in this new climate of interacting with patients and talking to them. So the next question, are there subtypes of autonomic dysfunction in long COVID? And are there clusters of symptoms associated with different subtypes? And does this affect the outcome? So I think this was partially answered in the talk that we still don't know and still at the stage of characterizing the spectrum of disease. And that was shown in our montage of tilt table data showing different physiological responses, and then some of the case series that we were talking about showing predominance of orthostatic intolerance symptoms without heart rate responses, and then some patients with a pure POTS or pure vasovagal phenotype. So probably too early to say at the moment. And again, this may reflect on underlying risk factors or predisposing factors as well as the fact that they've had COVID. I don't know if you want to add anything to that.
Apart from saying that the physiology is key here. So what you can see on the traces that we showed really tells you a lot about what's happening to the sympathetic nervous system in this patient. So whether or not you hit 30 beats a minute or 31 or 29, don't worry about what you call it. Because if the patients are symptomatic with that oscillatory pattern, then the physiology is very clear. They have this varying yo-yoing sympathetic expression that is causing heart rate and blood pressure to be high and low. And whether you can fit a diagnosis like POTS to that patient, it doesn't matter. The management should be very similar.
And now the next question is, could you, given the possible viral associated autoimmune theory, and we talked about the antibody responses, could you comment on therapies such as intravenous immunoglobulin or plasma exchange?
So this is quite an interesting narrative to go down, and I have huge respect for the work that's been done to search for these autoantibodies and the publications that have demonstrated the presence of this noradrenaline receptor antibodies, for example. Now, in my humble opinion, and here I don't really have experience bar n equals 1, and it wasn't a good experience on a patient who I forced to have IVIG but with no real impact. I would say that the autonomic nervous system is influenced in too many ways and too multifaceted in its inputs but also outputs that it's almost very difficult to pick on one endpoint pathway and say that will be the holy grail cure. So I know that sounds a bit odd and strange given that there is a clear mechanism of autoantibodies, but let me put it to you in a different way. When was the last time you had a common cold, and what was the thing that you did to heal from the common cold? I know when I have stress and I don't sleep for 3 days running because I'm preparing for a webinar, for example, I get mouth ulcers, and the thing that really cures me is a weekend of good sleep, 8 hours, 2 days in a row. And I feel my antibodies are better, I feel my immunity is better, and I feel less inflamed. And we all feel it, we all know it, we all instinctively know what it feels like to be good, not hungover, not lack of sleep, not stress. And yet we don't necessarily talk about it openly to our patients. And so I've started to do more of this because I believe the autoimmunity profile of patients can be enhanced by so many things before you get to IV, IG, and plasma exchange. And all those things really need to be carefully observed because they are really low-hanging fruit. And if you're going to give IV, IG to somebody who has toxic relationships at home, for example, who's not sleeping or who's stressed because the career is up in flames, then are you really helping that patient by treating that end pathway? So it's a very similar thing. And my view and my bias, and I'll admit I have a bias against beta blockers, midodrine, and everything else that we prescribe in clinic. Because if the patient comes to your clinic and says, I only drink tea and Coca-Cola, and I only drink 500 mils of water a day, what are you doing prescribing midodrine and fludrocortisone? You haven't even started at the base level. So I think it's interesting, but I think the patient selection and cohort that we choose to go into this therapy specifically, if we want to set them up to succeed, should be with the full knowledge that we have taken care of every other factor that can influence immunity. And I don't think we understand fully what those factors are yet, Mel.
And just in bullet points, tell us what you would say to your patients to optimize their general health. And this will actually come on to the penultimate question about vaccines. So if you're saying to a patient, how do you, or if a patient says to you, how can I optimize my general health? What's the advice that you would give as their doctor?
Sure. And this comes back down to basic lifestyle treatments. And this would be to ensure a good night's sleep, to ensure a wind down before sleep, so mobile phones away from the bedside, no bright light, and really give yourself a diarized sleeping time so that you're not chasing your email till midnight before you forget, because you need to really have time to calm down. So sleep is one, hydration is another, rest and recovery and me time is a third, and then a good diet. And for me personally, and here maybe people will take up an alternate view, but my idea of a good diet is a slightly lower carbohydrate, low sugar, low processed food diet, and a diet that doesn't make you feel stodgy with your food and feel unwell after you have a meal. So for example, for all those of you watching this webinar after lunchtime, think of how sleepy you're feeling right now. If you're feeling very sleepy, then it may be the diet that you just had for lunch, that big pasta bake or that chicken sandwich with fries, may be a bit too much carb for you because it's causing that splanchnic vasodilatation and for you to feel that feeling of slight low energy levels. And a good diet shouldn't really provoke that kind of response. And in my opinion, that's low sugar and low processed food, and potentially low carb as well. So those are the kind of key ingredients to promote immunity. And I guess that the question you're going to ask me next, Mel, would be top tips to prepare for your vaccine, right? And the top tips I would suggest to prepare for your vaccine would be to really have in your mind that the vaccine is there to help you and not to harm you. And I know that sounds super strange to say or to hear, but we must intrinsically and autonomically, i.e. subconsciously, believe that the vaccine is there to do good. There are so many patients I see who ask me the very same question, but immediately after saying, can I have the vaccine, they'll say, will it make my XYZ worse? Will it make my toes fall out? Will it make my palpitations come? Will it give me a heart attack? This sensation of fear and anxiety, guess what it triggers? It triggers an autonomic response, which is maladaptive. It triggers the fight or flight sympathetic nervous response. And what you need to go in when you're having a vaccine is a sense of calm and a sense that it will do you good. So that is your primed autonomic subconscious mind to receive the vaccine. Of course, the physical maneuvers that you should be doing would be to sleep very well on the night or two before, and certainly on the night or two afterwards, because the vaccine will trigger an immune response, and you should help that immune response present in the correct way or activate in the correct way by not overlaying any anxiety or tension or physical stress. And that means hydrating well, eating well, sleeping well, resting well, feeling well, and thinking well. So that would be my kind of top tips for receiving a vaccine.
That's great. Thank you. So you answered the question that was about to come. And then just moving on to the final question that we've got is you're evaluating and diagnosing these patients at the Imperial Syncope unit. Which facilities are available? And how should an autonomic testing lab be equipped to support physicians in diagnosing and treating long COVID?
So what's become very apparent is that a tilt lab with beat-to-beat non-invasive blood pressure tracers is incredibly helpful at demonstrating those oscillations that we showed in the panel of 8 tracers that we've shown. No doubt some of that can be detected by a standard upper arm blood pressure cuff with a patient describing or having the symptoms correlate with a pulse rate increase and a blood pressure decrease on the blood pressure cuff, but you don't always see it. And so if you have a patient who you're suspicious of autonomic dysfunction, as I said right at the beginning, the most discerning question is, how do you feel when you stand up? Or do your symptoms exacerbate when you stand up? And equally, do they resolve when you lie down and put your head down and put your legs on the sofa armrest or against the wall? Because if the answer to those two questions are yes, then it's very likely they have got an orthostatic component driving the symptoms, and then you can take a step further and surmise that that may be an indication of autonomic dysfunction. Now, how do you show it? You show it by means of a tilt table test. Can you show it with a blood pressure cuff? You might be able to, but remember the oscillations, you might not catch it at the right time. And so you might not see such a big delta between lying and standing. And so I think any autonomic lab should really have a tilt table test, or a tilt table plus a non-invasive blood pressure cuff. And that is the way that you could gain more clarity on the physiology of the autonomic nervous system as it relates to orthostatic challenges.
Well, with that, I'd like to thank you both very, very much for all of your insights today, both in your presentations as well as in this very informative and interesting Q&A session. And of course, a very big thank you to Finepress Medical Systems for making this event possible today. In closing, thank you again for taking part in this Inside Scientific webinar, and we look forward to having you with us again soon.